I'm Derek Hall, and we're going to be discussing ultrasound-guided interventional procedures for the wrist and hand. I have no relevant financial disclosures. I would like to mention this presentation is not meant to be a comprehensive review of this topic. Our objective is rather to cover the core competencies as outlined in the AMSSM recommended sports ultrasound curriculum for sports medicine fellowships. We'll be discussing 3 injections: carpal tunnel, forced dorsal compartment tendon sheath, and intra-articular wrist injections. For the carpal tunnel injection, our preferred approach is to have the patient seated. You can also have them supine, particularly if they have a history of vasovagal with injections, but seated is preferred if they tolerate injections and needles well. We'll have their palm up, their forearm supinated. The transducer will be positioned with a short axis view of the median nerve at the level of the proximal carpal tunnel inlet. The needle will be in plane, coming from an ulnar to a radial approach. Your target will be, effectively the carpal tunnel, but if possible, doing a hydrodissection around the median nerve may offer some additional benefit. You want to create a target sign around the nerve if possible, and the way you do this is by directing our needle tip both underneath and above the nerve so that we can get circumferential spread of injectate around the nerve. There may be some instances where it's very difficult to manipulate the needle tip like this, and so if you can only get the injectate under the retinaculum within the tunnel, that can still be an effective injection. So if based on the patient's anatomy and the surrounding structures, if you don't feel like you're going to be able to safely guide your needle tip in this manner, that's okay. Just placing it deep to the retinaculum within the tunnel, can still offer significant therapeutic benefit. But if you are able to create this target sign, that may be preferred. Our needle here is a 27 gauge, 1 1/4 inch. You can certainly use a slightly larger needle, but I would not recommend a longer needle as it becomes difficult to manipulate if the needle is too long. Injectate volume here can be variable. I don't like to put very much in this region, typically 1 or no more than 2 mLs. The transducer will be a high frequency linear. If you do have access to a short footprint, that can make things a bit easier for you as well. You want to identify and avoid the ulnar nerve and artery. As I mentioned, we're going to be taking an ulnar-sided approach, so you'll be coming over top of that ulnar nerve and artery, and so you want to make sure you have a good understanding of where those are prior to beginning. You also want to look for any anatomic variants. For instance, as we can see in these images, a bifid median nerve with a persistent median artery. You want to make sure you identify both limbs if this is present. So you don't want to target this part of the nerve here and not see this part and end up trying to put your needle right through the artery and the other branch of the nerve here. So you really want to look. And this is not an uncommon finding or an uncommon variant, so make sure you identify those. Moving on to our first dorsal compartment. The preferred approach here will be the patient seated or supine with the forearm in neutral. The transducer will be positioned in the short axis view over the tendons of the first dorsal compartment and preferably over the level of the distal radius. Your needle orientation will be in plane and typically will be coming from a volar to dorsal approach. There may be some variability here, again, due to the variable nature of the neurovasculature around this area. So although we say volar to dorsal, that's certainly not set in stone, and depending on the position of the superficial radial nerve, you may wish to take a slightly different approach. There may be an occasion as well where you're not positioned directly over the distal radius, again, because of the neurovasculature. So this is a good starting point, but make sure you do an individualized approach based on the patient's individualized anatomy. Your target will be the tendon sheath of the first dorsal compartment. It's very important that you ensure spread around both tendons. There will be a set of patients who will have a hypoechoic vertical septum that sits between the 2 tendons that effectively subcompartmentalizes the first dorsal compartment into 2 separate tendon sheaths. And this is a documented reason for failure both of injection and surgery for de Quervain's tenosynovitis. So we always want to make sure that we see adequate spread around both tendons, and if you're not getting that, you may need to reposition your needle tip beyond that septum to ensure spread around both portions of the first dorsal compartment. I prefer another short, small gauge needle here. Again, any of these hand or wrist procedures are much easier with a shorter needle. It's much easier to control. I prefer a 27 gauge. Certainly a 25 gauge would be reasonable as well. Injectate volume here will be 2 to 3 mLs. A short footprint transducer is helpful, but any high frequency transducer is adequate. You want to avoid the superficial radial nerve and radial artery. The radial artery will sit deep, and if you're over the distal radius, it should be at a safe location. There will be variable venous structures around, as you can see here. These can often be avoided or simply compressed. The superficial radial nerve should be identified. It will course over top of the first dorsal compartment, as we see right here. It's somewhat variable in its location of crossing as well as branching, so it may have branches. I've seen some that will branch and end up lying on both sides of the first dorsal compartment that can make using this approach a bit challenging and may require moving to a slightly different approach, coming more in plane with the long axis of the tendons. But typically you can find a safe zone coming in short axis and avoiding the neurovasculature. Lastly, we'll discuss wrist joint injections. For this, the patient should be seated and prefer the wrist to be flexed 20 to 40 degrees with the forearm pronated, using a pillow or other bolster to make the patient comfortable in this position. Your transducer will be in the anatomic sagittal plane over the radiolunate joint. Will be coming in plane from a distal to proximal approach. Your target will be the radiocarpal joint between the distal radius and the proximal lunate, as we see here, and advancing in. I prefer a small gauge needle again, so a 27, 1 1/4 for me. If you are trying to aspirate, you'll need to go slightly larger, so typically an 18 or 19 gauge needle for aspiration. Injectate volume is 2 to 3 mLs. A high-frequency transducer, again, a short footprint if you have it available to you, can make these a bit easier. Using an oblique standoff can be helpful. By that we mean putting an ample amount of acoustic coupling gel, and then this allows us to maintain a good image without having direct contact of the transducer on the patient. This will allow for a much easier tracking of our needle and a better angle that more corresponds to the joint. And that is our basic wrist injections. Thank you for your attention.